I'm Brad Stoner. I'm the Department Head of Public Health Sciences, and I want to welcome you to today's exciting Public Health Sciences seminar series. We'll start the seminar series today by acknowledging that Queen's University is situated on traditional Anishinaabe and Haudenosaunee territory. As uninvited guests, we are grateful to be able to live, learn, and play on these lands. It is my distinct privilege and pleasure to introduce Dr. Harriet Richardson, who is professor in our department, who will be moderating today's panel discussion. Come on up, Dr. Richardson.
Thank you, Brad, and thank you everybody for attending. Great turnout today. So I think we're going to in for a credit treat today. We've got Dr. Allison Mahar, Dr. Tim Hanna, and a future Dr. Chris Booth, who's just running a little late. So we're going to actually start. We've asked each of our panelists to give less than 10-minute overview, 5 to 10-minute overview of sort of what they're doing right now and where they. And so I think they've all got slides to share. And then we're going to open it up to panel discussion. So I'm going to actually ask Allison Mahar to come up first. So Allison, besides being a dear friend, is an epidemiologist and health services researcher at Queen's. She's an assistant professor in the School of Nursing and Department of Public Health Sciences. She completed both her MSc and PhD in epidemiology at Queen's University. I think under the what was with Patty Groom? Oh no, Anna Johnson for her master's and Patty Groom for her PhD. And then followed by a postdoc position in the cancer program at ICES. You hold a Canadian Cancer Study Emerging Scholar Award, and her grant research program is focused on using population-based, routinely collecting health and social data to address inequitable healthcare delivery along the cancer continuum.
Thank you.
Okay, you do a lot.
Do I need to?
I don't think you need to.
There's a lapel mic too if you want to use that instead.
I'm quite loud, so I don't want to yell into it. Can everyone hear me okay?
I don't know if the Zoom audience can hear you.
Oh.
Yeah, I think you have to be mic'd a little bit.
It's hard to hear at the back. Okay. Thank you. I will try not to, you're welcome, and I will try not to yell into the microphone because I am quite loud. Thank you all for this opportunity to be here back, in my home department to speak about some of the work that I've been up to with an incredible team who we're going to talk about. Really focused on the equitable delivery of cancer care. And for today's few moments, I'm just going to give you a high-level overview of some of the work that our team is up to set the tone for some of the conversations that we can have later. So the premise of my research program and the teams that I work with is around equity and health quality. So equitable delivery of care is one of the 6 dimensions of healthcare quality. So the work that I'm doing is really trying to improve the outcomes for all people living with cancer or diagnosed with cancer and their families. And so we take a real team approach in this research program. So that includes my colleagues who are also researchers, perhaps epidemiologists, surgical oncologists, medical oncologists, as well as centers, patient partnership. And so that includes people who are living with cancer, people who have survived cancer, and their family members and caregivers. It also centers the voices and perspectives of community members. And so that community can mean a lot of different things. Sometimes it's an organization specifically. So I've listed a few here that we work closely with. But it may also be communities of people with lived experience, in particular when it comes to doing work focused on health equity. That is a really critical point or consideration. And then I also just wanted to highlight all of the awesome trainees who are working with our team, in particular the work I'm going to talk about briefly today, and some of those even being in the room today or perhaps on Zoom. So when I'm talking about the equitable delivery of cancer care and health equity, I want to be really clear that here we're talking about the ways that our social, environmental, structural, political systems interact to have an impact on health outcomes. So we're talking about these upstream political and social contexts. So this is the framework from the World Health Organization. And so those being the real drivers of differences and disparities that we may see within a cancer population with respect to equity and the equitable delivery of care. Because they do influence these things like our social structures and systems influence our socioeconomic position, which can then oftentimes be measured in certain ways and thought about as the social determinants of health, and they go on to impact equity and health and well-being. So the work that I do is health services research, and it really relies heavily on the availability of routinely collected data to do cancer research. And so routinely collected data are those data generated during or from healthcare encounters. So those may be happening between a nurse practitioner and a patient in a clinic. They may be happening in a hospital. They may be between a patient and one other healthcare provider or with their family as well. And they're also happening within a policy context, which is really important because it determines the information environment or what information is actually collected from that encounter. So listed here are a few examples of things like personal health records or electronic health records, but they're also, in my case, so talking about things like the cancer registry data that are available, the emergency department data that are collected each time someone visits the emergency department. And these are, again, all happening within a socio-political context that can determine what types of information are collected, for whom, who's actually having these healthcare encounters within the cancer system, who has access to that care. And those all really feed into the sorts of research you can do around the equitable delivery of cancer care. And so I'm just going to give a brief overview of 4 of the sort of common issues that our team is usually trying to address when we're talking about studying the equitable cancer care delivery. So in one of the contexts is kind of the best one where you have so much data. So maybe you work at ICES, you have access to upwards of hundreds of data sets to work with, including the cancer registry, but you're worried about how you can use it appropriately to support informed, equitable decision making. So one of the things you may be familiar with or seeing a lot more of are risk calculators. So ways of bringing lots of different types of information together, quantifying risk of different outcomes. So in cancer, sometimes we're talking about personalizing an individual's cancer risk, an individual's likelihood of dying with their cancer, the best treatment that they should receive. And so some of the work that our team is doing is trying to explicitly think about how has equity been considered or is considered, both in the development of these sort of tools and how we bring data together, also how we use them at an individual clinical encounter, and also how accessible they are to different patient populations to help improve their care. And so you may have heard some of the news articles or some of the things that have been in the media around the ways that our data are collected and from whom are based often on racist policies, for example, which then determine the types of information that we can actually put into these tools and then create this opportunity to cause harm. So that's some of the work that our teams are doing, are to make sure that we think about equity when we think about the development and validation and use of prognostication tools in cancer. One of the other issues that our team is thinking about is that in these large data sets, some data are collected, let's say, on a topic that we're interested in, but we're not really confident that it's measuring what we want it to, or about the things that people want us to measure. And so through some funding from the Canadian Cancer Society for a project called Megan Can, which is measuring equity and generating action in cancer care in Canada, we're looking at things like, is a measure of neighborhood income, which is often used as a proxy for individual income in cancer health services research, is it really a good measure of what we think it's measuring? And the implications of that are pretty huge, because some people may think Canadian health system, universal healthcare access, how much money you have, it doesn't make a difference, when in fact, welcome, Chris. When in fact it can have a really important impact on your cancer outcomes. But if we aren't measuring income in the right way, we may incorrectly conclude that there are no issues to try and intervene on. And so some of the work that we're doing is looking to see, is individual income a good measure of neighborhood income, and then looking at different ways that we can incorporate individual level measures into our cancer health services research. Another issue that we try to tackle is for groups who are historically marginalized or excluded from the healthcare system. Sometimes we have data for those individuals and their cancer experiences, but no one is actually doing anything about it or using it. And that has real implications clinically, because it may mean that people do not have personalized clinical treatment guidelines, for example, and how their care should be delivered as a cancer patient. Perhaps they don't have the correct supports in place for them and their families to receive the cancer care that they need. And so some examples of work that our team is doing include kind of leveraging these large data sets at places like ICES and across the country to study cancer outcomes for people living with severe psychiatric illness, for example, or with intellectual or developmental disabilities, which I think you heard about at your Public Health Sciences Day from Rebecca, who is leading some of that work as part of her dissertation. And this has been a really important part of contributing to creating actionable evidence to improve the equitable delivery of cancer care internationally, because these are, for example, groups who are not a focus of cancer research globally. And so we're able to use some of these initial studies to create international collaborations to help improve outcomes for people and their families. And then finally, I'll just end with, because of how our social systems are structured, we often place value on particular things or people, and that is demonstrated in the information that we collect or do not collect about people, in particular, the data that make it into large administrative databases. And so there are many cases where people may be experiencing poor cancer outcomes. These may be preventable. They may be the result of discrimination or bias in the healthcare system, but we don't have any data that we can use to advocate for people and their communities. And so an example of this is that we're working on currently in our team is how to better capture information about gender diversity in cancer health services research, and to do so in a way that is safe and inclusive and engaged with the communities for whom those data would have real meaning and implications. So that's just a little bit about what our team is up to, and I look forward to speaking with you more about it. Thank you.
Allison. I'm gonna bring Tim up to the podium next. So Tim is an associate professor in the departments of oncology, medicine, and public health sciences. He is a clinician scientist at the Division of Cancer Care and Epidemiology, which is in our Cancer Research Institute here at Queen's. Yeah, radiation oncology clinical quality lead for Ontario's radiation team program, and he's also a radiation oncologist at the Cancer Centre of Southeastern Ontario. His work focuses on health services research and oncology with 3 translational streams: quality of care, value of care, and access to care. His value of care research touches on health technology assessment in the real world, particularly for novel therapies. He received his PhD and fellowship training at the Collaboration for Cancer Outcomes Research and Evaluation at Liverpool Hospital in Sydney, Australia. Prior to this, he trained at Queen's University in radiation oncology and completed an MSc with Dr. Bill McKillop and me, focusing on barriers to access to radiation and its impact on cancer outcome for endometrial cancer. Dr. Hannah obtained his medical degree at the University of Toronto. And he's just an all-around awesome guy. Here, Tim.
All right, well, I'll see how I do with the technology here. Yeah, so thank you. It's nice to have the chance to be with you and have this conversation. And I'm going to summarize some of the research that our group is working on under this title of Advancing Optimal Cancer Care Through Cancer Epidemiology. All right, it worked for me. So I'm going to take you through a few themes. One is measuring outcomes and effectiveness and cost effectiveness, both within the context of clinical trials and after trials. And then I'll talk a little bit about work we're doing around standardization and data, and then some specific work around treatment delay and outcomes. So it's really important to both measure innovations in cancer care and ensure that we're actually achieving better outcomes with these novel treatments, whether they're drugs or surgeries or radiation or other things. But it can take a lot of time and effort to collect the information you need within a trial to measure outcomes or to do a cost effectiveness analysis and economic analysis. So one of the things our group did was to look at whether we can harness the administered data, such as that which is within ICES, to measure what's needed to do economic analyses and measure outcomes. So this is survival figures generated by hand-collected trial data on the left side, and then on the right side using ICS data. Survival curves look really similar, and if you do the cost effectiveness analysis, you get an incremental cost effectiveness ratio that is also very similar. So some real benefits there because it's a lot cheaper to use ICS data, and we can measure outcomes for many things in perpetuity, which is really expensive within the context of the trial. Also, there's an important question about what happens in the real world. Usually on these trials, we're getting the Olympians of cancer care. That may not represent the real world population on many fronts. And in some ways, this is a kind of an equity question and an access question. And so it would be really nice to measure what happens in terms of economics and effectiveness amongst people that are represented in the communities that we live in. And so I've been part of some work looking at using sources such as ICS data, health administrative data, to do this. And this figure just shows a survival curve from an advanced melanoma study showing this treatment called pembrolizumab provides statistically significant improved survival compared to an older treatment. And we were able to emulate the measurement of outcomes and undertake an economic analysis in the real world and found essentially similar incremental cost effectiveness ratio and have a sense of whether the economic analysis at the time of approval really held or not, because it was based on a model, not real data. Just go ahead. And another question in this space is value, and there are all kinds of outcomes when we consider what the value is of cancer treatments to patients. We want to know about survival, but there are also other factors. You might want to know about toxicity or the time impact of coming for treatment. There are many other factors to consider. So this is just an example where we looked in the real world to see that melanoma, after there were a bunch of really expensive but slightly better treatments for advanced melanoma, did we see in the real world improvements in survival? Yes, we did. And you don't have to read this, but this is just showing you that we can measure costs for all kinds of things with ICS data and get pretty granular. And when we looked at details about cost of drugs versus other things, like stage 3 and 4 patients, and we compared eras, pre and post adoption of novel therapies, there were big jumps in the costs of treatment and healthcare costs due to drugs. But well, what does it mean to patients? And so we looked at something called time toxicity, and Chris can tell you more about that. He's been a real champion for that idea, along with Archie Coates, Eisenhower, and others. This idea that, especially when we're talking about advanced cancer, where you might not have long to live, there could be big impacts on your remaining time of life just seeking care. And so this is just an example showing that whatever era we're talking about, there can be big impacts on the time it takes for patients to come to treatment. In the case of advanced melanoma, it can almost be one day a week that you're spending just to seek the healthcare you need. I won't dwell too much on these other things. We can come back to them in our conversations, but more than just methods to do good cancer epidemiology and health services research, you need to have good data. And so I've been involved in some efforts to improve the radiation data in Ontario, and we can certainly chat about that. And this is also important internationally. If we want to be able to internationally benchmark and compare between countries and measure quality, we need to have interoperable data sources. And so there's an international effort that I've had the chance to be part of that's looking at recommendations to national cancer control programs to standardize data among many other things when they're planning for radiation. And finally, treatment delay and survival. This is something near and dear to my heart and many of our hearts. From during the pandemic, we undertook a systematic review of meta-analysis, looking all of the evidence for common cancers on the association of the time it takes from diagnosis to treatment and your survival. And when we published this, the editorial that was attached to it is what you see here. And the title was Prioritizing Research into Cancer Treatment Delay. One of the things we found was that we had to exclude numerous studies, almost half of the possible candidate studies, because the validity was so low, the information couldn't be used. It's wasted research, essentially. And so we're working, Cassidy, who's here, Matt Jalik, might be online, at a number of different projects looking at developing consensus-based methods so that as a community we can do this kind of research better.
Thanks, Tim. All right, last but not least, we're going to have Dr. Chris Booth come to the podium. He's a medical oncologist and health services researcher at Queen's University. He's a professor of oncology and public health sciences and holds the Canada Research Chair in Population Cancer Care. Dr. Booth is the director of the Division of Cancer and Epidemiology at the Queen's Cancer Research Institute. He studied medicine at Queen's University and is postgraduate training in internal medicine and medical oncology, also at the University of Toronto, followed by a research fellowship with the NCIC Clinical Trials Group, now the Canadian Cancer Trials Group. In his clinical practice, he provides care to patients with gastrointestinal cancers, and his research program explores access, quality, and value of cancer care in Canada and globally. Thank you, Chris, for coming. And also, big fabulous guy.
Hi, everyone. So I'm going to talk a little bit about how epidemiology and clinical cancer research has led to a foray into advocacy. So that's a lot of what I do right now is working in the advocacy space. And you'll see we generated some data over time, and now we're trying to be solution focused and not just describe problems, but work towards fixing some of the problems in the cancer system. So I'm going to open just with a paradox, and this talk, the next 8 or 9 minutes, is going to be the stuff you never read about in the Globe and Mail. You never hear about the cancer research meetings where you hear about the breakthroughs and the cure rates and the great things. And there have been a lot of really important advances in the treatment of cancer in the last 20 or 30 years. But there's also some problems, and I think you're getting a sense from some of the work that our group has done over the last number of years is shining a light on some of these problems so that policies and data and systems can be realigned to make things better for patients. So I had a sabbatical in India many years ago now, and so do a fair bit of policy work with the World Health Organization and also with colleagues in India, where I'm flying tomorrow. And so some of this has a global flavor. So the cancer medicine paradox, there is substantial overutilization of marginal, toxic, and expensive medicines in cancer, especially near the end of life. While at the same time, because of problems with access and affordability, most patients in the world do not get the cancer medicines which really make a big difference. And tragically, most of them also lack access to fundamental palliative care. And so this is just kind of highlighting what I've conceptualized as the cancer value crisis. And the value crisis is a convergence of a number of problems in our field. I've listed them here. I'm not going to go through them in detail, but they might come up in conversation. Clinical trials, which remain the gold standard for identifying new therapies. So the RCTs are still king and should be king or queen forever. They are the best way of identifying new therapies. There are problems, though, with some modern clinical trials in the way that they're designed, reported, or interpreted. There's a movement underway to actually abandon the RCT, which I think would be a disaster, because there's nothing wrong with the RCT. These are self-inflicted problems that the investigators and scientists have put in when they design the method. So there's some problem with clinical trials that can be fixed. And this has largely led to an outpouring of dubious endpoints. The primary endpoints have shifted away from what really matters to patients, living longer and living better, and now is shifted towards measuring tumors on a CAT scan. We'll touch on that. When we do find differences, the differences are often very small. The treatments have staggeringly high and unjustified prices. And fundamentally, there's a communication breakdown. And that communication breakdown happens at a number of levels. It happens at the bedside, the doctor-patient communication discussion, where often the relative benefits and risks of our therapies are not adequately described to allow patients to make informed decisions. There's a communication breakdown with the public, with the media, and with policymakers, where there's a lot of hype in our field. This comes from a place of good. People want to help, want to make a difference, but often the hype gets ahead of the reality and has led to some challenges. So this is a slide, this is a body of work that started when I was a young whippersnapper at Princess Margaret Hospital. And we published now 3 iterations of this where we've tracked, so I trained at Princess Margaret in the early 2000s, and one of my main teachers there was Ian Tannick, who together with Elizabeth Eisenhower and Bill McKillop are some of the luminaries in our field. And when I was a trainee, we tracked backwards looking at clinical trials in our field, and we've updated this now every few years. And so we've tracked primary endpoints, sample sizes, funding, and a number of other domains in clinical trials. And you can see in the 70s and 80s and early 90s, cancer investigators were designing clinical trials with overall survival as the primary goal. We wanted to help people live better. But what's happened over time is now less than 1/3 of trials are aiming to help people live longer. Instead, we use something called progression-free survival, which is essentially measuring how long does it take until the tumor grows on a CAT scan. So about half of clinical trials are now designed to test tumor measurements. This came again from a good place. People thought it would predict overall survival, but in most circumstances, we've learned that's not the case. And then you can see the other striking curve there is in the old days, most clinical trials were funded by government grants or philanthropic groups, and now the pharmaceutical industry controls everything. They fund 90% of the clinical trials in my field, which, as you can imagine, is a problem. So a lot of the new cancer medicines coming out do not help people live longer. Some of them do, and there have been some transformative medicines in melanoma and breast cancer. There's been some big advances, so I don't want to come across as purely critical, but I think we need to have some humility in our field. And so when we looked at all the drugs approved by the FDA or the Health Canada or the European Medicine Agency, you can see only about 1/3 of them now help people live longer. Most of them shrink tumors on a CAT scan. And this progression-free survival might be useful if it's a surrogate for what matters to patients, but we've learned that's not the case in the vast majority of circumstances. Progression-free survival might also be useful if it has intrinsic meaning to patients. The idea that cancer is not growing intuitively makes people feel good, but we've actually conducted a study here using mixed methods approaches where we interviewed real patients with lived experience on palliative chemotherapy, and they were pretty clear that when you consider the side effects, the toxicity, their time, they're not very interested in treatments that don't help them live longer but just shrink tumors on a CAT scan. And then the interesting methods problem is even if number 1 or number 2 is true, because of something called informative censoring, we believe that actually a lot of the apparent improvement in this endpoint is actually false, it's artifact. So we've got a big problem in our field because about half the trials are now designed to measure something that probably doesn't matter or is not very measurable. Amongst the medicines that do help people live longer, again, there's some blockbusters add many, many, many months or years of life and cure patients. Okay, that's a different bucket. But in aggregate, the added amount of time is 3 months. And I spend my career looking after patients and families with advanced cancer. So I don't want to take away the meaning of 3 months of life. But we need to remember, as Tim said, there's a big gap between what happens in trials and what happens in practice. Okay, so that 3 months is almost certainly 2 months, 1 month, 2 weeks in the real world. But then also there's the patient lived experience. They have to live with the side effects. In many health systems, there's huge costs to the patient and family or the health system. And the concept of time toxicity, especially when life is short, if you have 6 or 12 months left to live, and you're going to spend every Monday in the chemotherapy unit, that's a big opportunity cost for you and your family. So these are the types of honest conversations I think really need to happen in our field. So, a number of months ago, we decided to stop complaining about things and to be advocates and do something about it. So we had a planning meeting in Kingston, and we launched an initiative called Common Sense Oncology, which is really driven around getting cancer care and research back to the outcomes that matter to patients, which is living longer and living better lives. And so we hosted a planning meeting of about 30 people in Kingston. This was a group from 15 different countries, oncologists, academics. We had the editor of Lancet who attended, and 4 patient advocates. And for 3 days here at the Donald Gordon Center, we had vigorous debate about what were the key problems in our field, what were we going to tackle, and how were we going to be solution focused. And from that came what's been called the CSO Manifesto in Lancet, which was published in July, where we outline what it is that we want to do. And so the mission of this movement is to be this broad, inclusive group, bringing in all stakeholders in the cancer system. And we want to create an environment where we can have these honest conversations about challenges and problems and work towards solutions. So we want cancer systems to focus on outcomes that matter to patients. And there's a heavy global health equity, health justice angle to this, because 2/3 of global cancer cases now happen in lower and middle income countries. And so a big part of this is promoting access and equity, not just overseas, but even in our own system, as you've heard from Alison and Tim, where there could be big equity gaps in care. We have a series of guiding principles that access is a fundamental right. Patients and societal needs should drive everything we do, not corporate profits. Patients and the public should be involved in setting policy. Shared decision-making, truly informed shared decision-making with the patient should be driving everything. And fundamentally, treatment should be aimed to help people live longer and better lives. So just the last slide here before we start the conversation is we had to be pretty strategic about, well, what are we going to tackle and how are we going to work on it? So we came up with 3 core pillars of work, and this prompted a kind of work stream, and there's project teams under each of these pillars. And those pillars are evidence generation, evidence interpretation, and evidence communication. And the idea was upstream of every clinical or policy decision is the evidence upon which those decisions are made. And our group believes that RCTs are the gold standard evidence. So the first pillar involves trialists from all over the world that are working to ensure that clinical trials are designed and reported consistent with the outcomes that matter to patients. We're partnering very closely with cooperative trial groups around the world, and the Canadian Cancer Trials Group here is one of the leading figures in that space. And generally, it's not the cooperative trials groups that have the problems, it's many of the pharmaceutical trials that are not run through academic units. The second pillar of work is evidence interpretation, where we want to train junior oncologists, residents, and practitioners skills in critical appraisal, skills that you're learning in your epidemiology class, how to dissect a good study from a bad study, strong evidence from poor evidence. And we also want doctors to become critical thinkers. In training, we're drilled into our head to follow guidelines. Guidelines are useful, but they may not always apply to the patient sitting in front of you. So we want to foster a culture of critical thinking and critical appraisal. So that's an educational bucket of work. And the third bucket of work is probably the most interesting and the most challenging, which is communication, which is working with patient advocates to understand their priorities, how we can better explain the treatment's benefits and risks at the bedside, but then at a broader level, how we can communicate to payers, policymakers, and guideline groups about the outcomes that we think are most important in our field. So there's a project teams assigned with all this. I should mention that stakeholders from around the world, including patient advocates, are embedded in these teams. And we had our public launch in July when the Lancet paper was published, and it's since kind of grown. This is a very broad movement, and I literally get several emails every day from patients or policymakers or advocates or scientists all over the world saying that this resonates with them and their system for a variety of different reasons. And in closing, I'll just paraphrase here a little bit about the movement. Common sense oncology will promote interventions that measurably improve the lives of patients. We will celebrate well-conducted trials and promote effective treatments, but we will also speak up about and challenge interventions that might cause more harm than good. We seek to decrease global and regional inequities in access to affordable, high-quality care. Improvements in the generation, interpretation, and communication of evidence will help close those gaps and move our field closer to a future in which a patient's outcome is not determined by where they live, what they can afford, or the strength of a marketing campaign. So we have a website, and some of the Twitter savvy people in our group have a Twitter following. So I encourage, this is we're open, anyone who would like to join. There's a free membership, you get our newsletters. We're just looking to build a coalition of people who are interested in improving things for patients. Thanks for having me, and happy to look forward to this.
Thank you very much, Chris. Awesome work that you're doing. I'd like to open up the panel, the discussion now to audience. I do have some questions, but does anybody have a burning question right now that they'd like to ask? No. Okay, I'll start it up. Okay, so I guess one of the questions that I had, is what, I guess maybe this might be to all of you. What either technological or methodological like developments, do you, okay, what do I have here? Are you most excited about in either medical oncology or sort of in the health services research area? And it doesn't actually really, yeah, you've spoken much more about sort of the equity that you've been doing and equity work and sort of access to care. So this question doesn't necessarily map onto that. That's more of a technical question, isn't it? But are there, so are there new developments that you see as being important in informing your daily methodological research that you're doing? Sure, Allison.
You want to pass the microphone?
Yes. Or Tim, whoever.
Oh, okay, well, this is good, I can use this for now. Yeah, I mean, there's lots of things to be excited about, as you've heard from all of our talks. I think I'm excited about standardization of data and pooling of data from larger and larger regions, simply because we can't answer health services questions and questions that matter to the public and to patients without that. So for example, the work looking at radiation programs standardizing their data sources so that we can benchmark quality between countries. I find that, I mean, it's not a really cool AI method or anything like that, but when we're all talking the same language, we can do a lot more, and there's a lot less data waste when we do things in a standardized way that we can. So from that point of view,
So I can talk a little bit about two things that I'm excited about that are actually methods focused. Because the space of health equity and how to consider it quantitatively in epidemiology is not necessarily a long-standing consideration. And so one of the really cool things coming out of Harvard right now is the idea of the decomposition of health equity effects. So it's a mathematical structure for thinking about confounding in a different way than we may have previously done so, and some of those traditional confounding variables. So when we are looking at a question of health equity and we want to understand, for example, cancer outcomes for someone with a severe psychiatric illness, we're not talking about a biological relationship between that mental illness and cancer outcomes. We're talking about this constellation, complex factors that are associated with it. And so sometimes we can get challenged, well, why aren't you including income in your model as a confounder? Why haven't you adjusted for comorbidities? And this decomposition framework for health equity actually really clearly positions the importance of not just thinking about our traditional equity triangle, but also thinking about the ethical implications of including that variable. The kind of upstream reasons for why someone may have low income or may have additional comorbidities and whether or not they're modifiable. And if they are, then they're not truly, causing your exposure and your outcome. And so I think that's a really exciting way of thinking. It's really new. I would say many journals do not yet know about this approach, but it's hopefully one that you'll get to learn about in some of your classes as well.
Just want to take, you're good, you're good. Okay.
There's a microphone up there for you.
Where?
Right, sorry.
This thing?
Yeah.
Okay, so I'll leave this down. Okay, all right. Well, Allison, I think maybe we'll be asking you to come and talk to our.
I think you can ask Rebecca. Rebecca's getting very good at explaining what we're trying to do.
Chris, I'm going to ask you to could you tell the group the difference between like a cooperative oncology group versus a pharmaceutical-led trial? Because cooperative oncology groups do often partner with industry. So what makes the outcomes of those trials potentially different from, say, pharmaceutical-led trials?
Yeah, great question. So, I mean, I should take a step back. I've been very critical of pharma in many regards, but it's worth saying that some of the best treatments we've got and some very, very good clinical trials are done by the pharmaceutical industry, either on their own or in partnership with academic collaborative groups. So I'm not proposing a scenario where we have no funded trials by pharma. But when they fund 92%, there's some problems because the primary goal of a pharmaceutical company, and this is a fiduciary goal to their shareholders, is to generate as much revenue as possible. And we shouldn't apologize for that or put that down. That's their job. And the job of the health system is to deliver high quality, affordable, accessible care to everyone. And there sometimes is convergence between making money and helping people, but often there's not. In fact, we had a paper in Lancet Oncology a few years ago where we asked a very pragmatic question. That question was, if Allison wants to get to work faster and she wants a nicer bicycle or skateboard, she spends more money and gets a nicer skateboard. And Tim wants a bigger house for all of his kids, he spends more money, gets a bigger house, right? That's a relationship that we have every day, is this cost and value relationship. We asked whether that relationship is true for cancer medicines, and we found that not only is there no relationship, if anything, there's an inverse relationship, whereas the drugs with the smallest benefit have the largest price tag. So it's a completely broken system. So that's just a bit of background about kind of, priorities of pharma, and they shouldn't have to apologize for that. That's their mandate. But as Harry has alluded to, there can be very rich partnerships when the pharmaceutical company, which has money and an exciting compound or drug, partners with an academic cooperative group, which is generally led by physicians and scientists who are aligned with the priority of helping society and patients. And that's when very helpful trials can happen. And we've shown that trials done by cooperative trials groups are more likely to measure outcomes that matter to patients. They're more likely to measure larger effect sizes. There's still a lot of work to be done, even in the cooperative group framework. But it's in the pure pharmaceutical trials tend to be where you see some of the games with an inadequate control arm, inappropriate crossover, some of the reporting problems. And so there is a distinction. And certainly, the Common Sense Oncology movement, one of the things we want to do is support reinvestment into the cooperative trials groups so they can answer questions that pharma doesn't care about. What about meditation, yoga, exercise, or how to train physicians and nurses to do a better job breaking bad news? We need trials for that. Or how to de-escalate the intensity of therapy, maintain survival, but improve side effects and quality of life. So there's a lot of work to be done in that space, but there are some key differences.
Okay, is that a question?
Yeah, it's quite a pragmatic question, Chris. To me, it looks like CSO needs some funding to get better. And so my question is it totally voluntary at the moment, A? And B, will there be opportunities to find some income?
Yeah, it's a great question. So I'm waiting for Roche to get back to me. No, pharma is not a big fan of Chris Booth, but you're right. So we're going up against $100 billion a year industry, and we're trying to be careful with messaging. We're not anti-pharma, we're pro-patient. And we have basically no resources. We're starting to get donors, patients, and groups stepping forward, philanthropic groups. We got a random phone call from a retired US oncologist a month or two ago who said, I've been waiting for 10 years for someone to do this. I'm mailing you a check for $50,000. I want you to train the next generation. And so we're just launching the Common Sense Oncology Research Fellowship at CCE. So we're slowly moving in that direction, but you're right, it's an uphill battle. I mean, along the lines of reinvesting in cooperative trials groups, I've always thought it crazy that our health system, I'm just writing a paper with Cancer Care Ontario now, we spent $1.7 billion last year on Ontario on cancer drugs, $1.7 billion. And how is it possible that they don't invest a fraction of that back into real world data studies to make sure there's equitable access and outcomes in the real world? And there should be also investment into pragmatic clinical trials to look, can you give shorter, less intense treatment, reduce costs, help patients, and preserve outcomes? So I think there needs to be kind of creative thinking about how to fund these things.
Any other questions? Brad.
So I've got a question. So you're all setting equity at some level. Chris, how do these drugs get approved by regulators if the outcomes aren't common sense outcomes? How do the FDA and the Canadian equivalent, how do they come to market if the endpoints are based on these things that don't matter?
Yeah. So I wrote an essay about this a few months ago, and I think we've gotten into this problem because of a convergence of two powerful forces, hope and money. Okay. The hope is that everyone in the system wants to make things better for patients. Okay, even pharma. Okay, they want to make things better for patients. And there's the hope that this is going to help someone. There'll be an exception that this drug is going to work better than we think. So there's hope. but there's also so much money at stake. We had some students a couple of years ago review the financial statements for every the top 10 pharma companies in the world for 10 years. And we just stratified their sales revenue as cancer drug or non-cancer drug. And over a decade, the entire pharmaceutical industry has pivoted away from other diseases into cancer. There is a lot of money in the system now. And when you have a lot of money in the system, there could be problems with that. And so one of those challenges is, and this goes back to the FDA. So legislation in the early 1990s mandated the FDA by law to approve any drug, which was a little bit better than the previous drug. Okay. And then by law, Medicare and Medicaid have to pay for it and they cannot negotiate price. It's like a crazy system. Most Americans don't know this, most oncologists don't. It's an unbelievable system. They cannot negotiate and they must pay for it. So that's had a trickle-down effect the rest of the world. Now in Canada, we're lucky, and just like in the UK and some other countries, we have a two-step system. We have a regulator like Health Canada that says the drug is safe and can be used, but then we have a health technology assessment program where the Ministry of Health or Cancer Ontario looks at the benefit, looks at the price, negotiates with pharma, and then decides are they going to pay for it, yes or no. So we're a little bit more protected from these problems in Canada, the UK, or Scandinavia, but we're all vulnerable because the FDA and the US market is so huge.
Jessica, do you have a question, Jessica, or you're pondering?
Sure. I have a question for Allison. We were chatting about, I think you said it was the Mega Can project, looking at how aggregate income potentially is a good or poor estimate of individual level. And I was reading some papers about this over the summer, and they sort of reported a difference on how the comparison is for absolute measures versus relative measures, and how sometimes in relative it can be a closer proxy. I don't know if that's something you're looking at, or if you could speak more about that project in general.
Yeah, so thank you for the question. There's kind of two there. So I can comment specifically on the income question, and then Mega Can is actually much bigger than that. I shouldn't have reduced it to one very, a small part of what we do. Just to quickly say that the Mega Can project has a number of different steps, one of which is partnering with patients to find out what they see as being the priorities for addressing inequitable delivery of cancer care in Canada. It's looking at the literature to see what's already out there and where are there gaps and where do we need to respond to those gaps. It's using administrative data and good ways to develop new measures or better measures to address gaps in evidence. And it's also generating educational resources for the research community to do better work when we do want to answer questions. So thank you for asking me to clarify that. And then with respect to the relative versus absolute differences, I'm not sure which papers you're referring to specifically. I know the work that our team is currently doing is being led by a PhD student at McGill, Laura Davis, and she has published on misclassification essentially. So looking at if you were classified in the lowest income quintile at the community level, are you also in the lowest income quintile at the individual level, and then kind of seeing how that misclassification has an impact on different outcomes that might be measured along the continuum. And I won't speak, I can't speak specifically about those details. I do know the relative and absolute differences when we looked at survival in colon cancer were different in magnitude when you between the individual and neighborhood level effects. But I will say that what we're finding is that misclassification is differential. It depends on a number of factors. It depends on the outcome itself. And so there's really at this point not a clear kind of, this is how you should approach individual versus neighborhood level measures and how moving forward in cancer research. Yeah.
I was actually going to ask about the outcomes and how that might sort of change how you look at, area level, SES versus individual level SES. So,
yeah, well, Laura's doing some really cool work. And so she's done a quantitative bias analysis, and she's created kind of adjustment factors for studies that only have access to neighborhood level income, but it's really dependent on the outcomes. You can apply it in your setting if you're also interested in survival, for example, in colon cancer, but there's no one factor that you could then use to adjust all, studies moving forward.
I've heard a lot about patient partnering, especially you, Allison, you're doing a fair bit of that. What about Tim and Chris? Like, how do you partner with patients in your various research programs? And is there room for improvement?
Yes.
Move on, next question.
No, I mean, it's really important. I personally don't do it enough. I want to do it more. I mean, it can be hard as you're getting into it and as an early learner. to understand how to place patients and those with lived experience into your work at appropriate times. So, for example, if you're having a biostatistical discussion and a detailed methods discussion, you don't want to waste a person's time to come and just sit in the background and listen to that. But when you're doing other things like maybe deciding what your research topic is or the questions that you want to ask in the qualitative study, there's a lot of other opportunities. So definitely it's crucial. I know GCRI is working at improving connecting researchers with those with experience. Maybe I'll just stop there.
Yeah, I've gotten into space just in the last few years, so I think this is the way of the future. This is the way it should be. I think the idea of co-creating, so as Allison said, what are the burning questions and what are the problems that the patient and the stakeholder community sees? So we do that as a CSO. We've got engaged stakeholder. We have a patient advocate leading one of the work streams. And the tricky thing, and I'm still learning how to do this, is obviously any patient representation is valuable and helpful. But just like patients in clinical trials may not represent the average patient in routine practice, the patient advocates or the people who step forward for these committees are often very different, and in fact can be very, very different. So there's professional patient advocates in different parts of the world, some of whom are funded by pharma, ironically, there's another discussion. And they're very thoughtful, they've had lived experience, very bright. But I can tell you that their opinions about things are 100 times different than the patients I just looked after this morning who live in small towns around the Kingston countryside. So there's a big disconnect there. And so I think trying to engage patients that actually represent the community is, the next challenge for me in my work is to find those patients and engage.
Excellent work. Okay, I think we have time for one last question. Duncan.
So this isn't a question. I just thought that people in this room might like to know that all 3 members of our panel took Epi 801.
I might have one more question then, just to follow. I wonder, I just saw this question, so I thought, that'd be a fun question to ask you. What have you read lately that might have changed your perspective on a topic near and dear to your heart in your research programs? I was mostly watching Netflix at night, so I wouldn't be able to answer that question. I don't say pass, just say.
Give you guys some time to think about an answer. This is just first thing that comes to mind. I treat skin cancer as a radiation oncologist, and I saw there was a randomized trial looking at comparing 2 different approaches to dosing radiation, and it changed the way that I thought about dosing radiation. And it's just a simple example of how randomized trials are so important to our decision making, and there's vast areas of very practical issues that we manage every day in our practice, where we just use first principles in case series, and having good data can dramatically change our thinking very quickly in some cases.
Great. I'll give the pass to the others unless they have something burning.
Well, I'll mention, so other than Harry Potter, which I read last night for the 84th time with our youngest, which is still a good book. So, I mean, this is going to be way out there, but I recently reread the book, The Alchemist. And I think this is actually important for the people in the room who are going to be the next generation, which is follow your passion, follow what gives you energy and a burning desire to learn about and to create a better place in the world. So I think that you're in an exciting time. 2 of us are old timers, one's a bit less of an old timer, but you're the next generation. And so I think that the next generation is much more aware of these big picture issues, right? The 3 of us are a little bit outliers in our field because we do this type of work, but I think this is going to become more mainstream. And it'll be your generation that makes these ideas more mainstream. So I think that's very exciting. So I'll leave it at that. It's a good book if you haven't read The Alchemist.
Allison, any of that?
I don't feel like I can follow that one up, but go on and live your dreams. Good way to end today.
And the next cancer book I read not that long ago was The Emperor of All Maladies, which is a wonderful book if you haven't read it and you want to understand more about the history of cancer care and treatment. Okay, well, I give a huge round of thanks to our lovely panelists.
Thank you, Harriet. Thank you, panelists. A fantastic presentation. Exactly what we're hoping for. engaged discussion. Thanks everyone for coming. Just a plug for our next presentation 2 weeks from today. Dr. Gerald Evans, who's the head of infectious disease, is going to be talking about learnings from the pandemic and infectious disease doctors' perspectives about his work at COVID. Okay, thanks for coming and